Hello, this is Ryan Farhat. I'm currently a PGY1 at the University of Arizona College of Medicine, Phoenix, and I'm here to talk to you today about a patient I had who can I help identify an active vasculitic disease, especially in a patient who has a very complex history. So, my patient is a 30-year-old female. She had a history of FSGS, status post renal transplant back in 2019. Who is on mycophenolate and tacrolimus, and she presented with nonspecific URI symptoms and poor oral intake. So she was around a sick contact throughout the last month prior to her admission, but she had a couple days of hemoptysis. She mentioned that her sputum was a little bit blood tinged. She also had nausea and intractable vomiting. The hemoptysis seemed to go away for a little bit of time, for a couple weeks, and then re-presented a week prior to her admission. She continued to have nausea and vomiting for the prior 2 weeks, which caused her to have very poor oral intake, and she was non-compliant with her tacrolimus and mycophenolate for the last week before she came into the hospital. So for her most notable symptom was her severe hemoptysis. On initial presentation, though, her vital signs were completely normal. She was satting well, she was on room air, and her hemoglobin was 5.8 in the ED, and she was transfused with 2 units of blood at that time. Her creatinine was 17.76, and her BUN, as you can see, was 101. So in the ED initially, she received a chest x-ray, which is shown in the middle column, and shows those diffuse alveolar infiltrates. The left seems to be a little bit worse than the right. And initially, we were thinking along the lines of this could be potentially a multilobar pneumonia. But when we looked at her, she didn't have a leukocytosis, she didn't have a fever, so it didn't really fit the picture, but we had started her on azithromycin and ceftriaxone initially, thinking that it was more of an infectious picture. So, with all of that information, essentially, we had a patient who was coming in after 1 week of being non-compliant with her immunosuppressive therapy. She was in acute renal failure with a creatinine of 17.7. She had very poor oral intake, and she was having blood loss anemia, which we were unsure of where this blood was coming from. So for her, we were trying to keep an open differential at the start. We were thinking along the lines of an infectious etiology. It could be viral, atypical mycobacterium, fungal infection, bacterial infection, or potentially a new autoimmune process such as a vasculitis like Wegener's. So at the time, we ordered a CTA, which, as you can see in column B, shows a lot of those diffuse bilateral alveolar infiltrates, but when you put it in the clinical context of acute blood loss anemia, we realized that this was actually blood that she was losing in her lungs, which was contributing to her symptoms. So she had acute pulmonary hemorrhage syndrome with acute renal failure in the setting of a prior transplant. So the antibiotics were discontinued at the time, and we reached out to pulmonology for a bronch to obtain some cultures. So we were initially thinking potentially PJP, although a lot of her vital signs were stable, and she was clinically stable at the time. We did a cocci serology, a respiratory viral panel, CMV, and then also ordered a lot of the autoimmune tests, C3, C4, and then ANCA labs as well for her. So, as you can see in the middle column as well, her ANCA came back positive, as well as her myeloperoxidase antibody and proteinase 3 antibody. And all of her other labs were largely negative. Her negative RF, CMV, BK, PJP, and on her bronchoscopy, she came back having Legionella, but lacked any other findings for commonly associated immunocompromised hosts, such as PJV or or CMV. And given her acute renal failure in the transplant patient, she underwent a biopsy which showed focal necrotizing and chronic glomerulonephritis with microvascular thrombi. So she ended up having acute renal rejection, but also on top of that, given the findings of a positive ANCA and the findings of focal necrotizing and chronic glomerulonephritis with no granuloma formation, we ultimately diagnosed her with acute pulmonary renal syndrome due to microvascular polyangiitis. And her rejection that she was also having was due to her non-compliance with her immunosuppressive therapy. She had this intractable vomiting for a week prior to her presentation and was unable to take those medications at the time. So for her, she was diagnosed with these conditions. We ultimately consulted ID, pulmonary was on board, rheumatology was on board, and she was ultimately treated with plasma exchange, thymoglobulin. She had pulse dose steroids on board, rituximab, and she was transitioned to hemodialysis when she was closer to discharge. So this case was, I think, very helpful in helping to identify an active vasculitic disease while also keeping a broad spectrum in mind of disease process that can also present like this. I think initially we were thinking along the lines of an infectious etiology or something that would be associated with immunocompromised hosts such as PJP, but all of those were largely negative, and we ended up figuring out the p-ANCA labs were positive and ultimately diagnosing her with MPA and acute pulmonary renal syndrome. So for her, this identifies the need for a broad differential, especially in patients who have a complex history, considering she was immunosuppressed and she had a transplanted organ. So patients with active organ failure, such as glomerulonephritis or pulmonary hemorrhage, should prompt a workup for vasculitic or autoimmune causes, in addition to all the infectious etiologies we talked about earlier. And in the case of microscopic polyangiitis, it is important to initiate treatment pretty quickly with rituximab or cyclophosphamide, as there are studies that show that patients left untreated have a mortality rate of up to 90% within 2 years. So again, my name is Ryan Farhat. I'm a PGY1 at the University of Arizona College of Medicine, Phoenix. Thank you very much.